Okay, welcome to another case study. This is an extremely difficult case to go through on one hand in terms of actually trying to provide a service to a patient, but otherwise it's a very easy case to diagnose and treat because there's really nothing to do if you just give up on this person. We're only going to talk about the bone assessment in this case study. We're not going to look at the soft tissue or any of the medical history. There's so much to talk about just with bone anatomy of this case, and that's what I wanted to talk mostly about on this case, is really that this person has that kind of perfect storm that is just inherent in his oral problems, whether it's psychological, habitual, that he has problems like with drinking too much Coke or sugar or drugs or medications or whatever it is that causes teeth to rot away. Unfortunately, his bone anatomy is a genetic component that has really enabled a very, very difficult case to actually help this patient. In fact, there's so much red across the board that the upper denture, there's really nothing you can do for this case. If I guess maybe some oral surgeons can try to do something like the zygomatic arch implants and do something like that. That's a bit heroic in my opinion and doesn't have a long life cycle, and it can have a lot of inherent risk with zygomatic arch implants. And plus, it'd be hard to find a dentist that wants to take on that prosthetic on the zygomatic arch implants. So I don't recommend those. And if you are doing that, then hopefully you can find somebody to help service that, or you stay with the dentist or whoever that's helping you out with those complicated type of implants. And, you know, that's kind of it. So here is the case. He's got really no upper teeth at all. His upper teeth are pretty much all gone for a long time now. That's nothing new to him. His denture kind of works, and his lower teeth are really rotted out. I think that finally got to him, that realized that he can't fake it anymore. He can't deal with it anymore. There's pain, there's issues like that. But let's talk a little bit more about the anatomy. Here's the two-dimensional view of this on the x-ray, and they're already rotted down to the core. And let's just quickly take a look at the upper case, and let's take one arch at a time. So when I scan through, what I'm going to do is just take this and start over here in the upper left side, and I'm going to just scroll across so we can just kind of look at the bone anatomy. And we'll talk a little bit more about that. So we're going to first look at that sinus. So that's a red for the sinus. And I'm looking right in this particular area. And I'm going to start scrolling across, because that would be really where I want to start with any implants on the upper. You want to go as back as far as you can in some solid bone. And if he wants, he could try to do a bone graft here where you build up a lot of bone. So you would have to build up bone way up here, which you could do. So there's oral surgeons in the country that do this. So just because I don't do it doesn't mean that another oral surgeon or some sort of surgeon would actually do this. So the problem I see here is there's not a lot of bone healing capacity. And so the best type of graft you would do here is called an autogenous graft. So you could get something here, and you would have to drive all of that material up to this point here. But still, one of the problems you have is that if you're here, that's the most forward part of the implant you could go. So let me just draw a line right there, which is pretty far back. You're already into this second premolar area in terms of function. And that's a big problem. So you do all this work trying to get the graft up into the sinus, but his sinuses are big, but they're also further back. You don't have a lot of healing capacity, so even if you do get that bone to heal, you're ending up with a prosthetic that's going to have implants way in the back. And so as you go forward, let's keep going forward from that point, and you can see how knife edge that bone actually is here. That is a very, very difficult scenario to deal with. You can't do much with that bone. It's just a very thin layer of bone. You can't build the bone out very well. They can try block grafts, but it's so thin that there's probably not a lot of capacity once you start screwing blocks into that area. And that would be very difficult to try to achieve something there. And as you keep going along, look how much worse it gets. That little sliver goes even away when you get towards the center. And that's because he has something called combination syndrome. And we've talked about that in other videos. If you look at the assessment videos, we talked about the segment on combination syndrome. And that has to do with the bite characteristics part of our assessments. And what happens is that the natural lower teeth cause resorption on the upper arch due to the fact that the upper arch is getting tortured by the upper denture just pushing against the gums. So now when we go to the other side, and you can see how his bone actually has folded into that real sliver again all the way across. And the reason why it's such a sliver is because he didn't have any facial bone, and he had a real big constriction. He had a combination of two things that ends up following this pattern. And if we look at that lower tooth right here, he's got a massive cavity into the nerve, and he looks like he's pushing something in there to pacify the nerve. So something that he got off the shelf and it's kind of just pushed in there. Well, that only works so far before it starts rotting out more bone down here. So you can see right here, he's got a very, very thin layer of bone here, but it's very, very thin. He's got a thin layer of bone here. That's because this bone constricts. It almost goes parallel, but it has a little constriction coming in here, and it's even worse when you actually look at it across other teeth, where it really comes together, and it makes it very, very difficult that there's really no bone around those teeth. And when those teeth get extracted, it basically creates like a knife edge that's going to go up only to the height that you have, and now you would have bone going like this and then down. Just like you had a tooth out here that goes away, and now you can create that little knife edge here. So that's unfortunate for this person. So he's a red on facial bone, he's a red on the constriction part, and then when you get over to the sinus, of course, he's a red there. I can't go up here. This is a nasal sinus. This is the start of the maxillary sinus up here. And he's ending up with possibly very little bone here. If he does a sinus graft on this side, he's still stuck with trying to put a lot of bone up into the sinus area here to get implants in there. But then he's stuck also way back in the mouth. So you're stuck way back here, and they're back into that second premolar area on this upper area. And the problem there is, again, you have an entire whole front. Most of your teeth on a prosthetic in this case will not have any support, which it won't work very well. You'll constantly be knocking it out. So that's a huge, huge problem for this patient on the upper case. So the bone density doesn't look good either. So if we look at that bone density, that's pretty porous there, and looks kind of like the characteristics aren't very good anyway. So on the upper, it's kind of red, red, red across the board, and about the only thing that's not red is probably the yellow detached gingiva column that I have. But everything else doesn't look good at all upper. So I would say you don't do anything on the upper, and you just have to deal with being a dental cripple or somebody that just has to deal with the traditional denture. And that's about all you can do on this case. If you look at the bottom now, because the bottom has that constriction as well, and that makes it very, very difficult to actually do anything. And you can see here it becomes a little bit more knife edge in the back of where you want to be putting an implant. That would be right here. And you can see the nerve coming out of the jaw right here. And so if we could get an implant there, that would be ideal for a 4-locator case or a hybrid case or whatever you want to do. But there just is not enough bone, and the bone kind of looks a little splotchy too. So the bone quality is not very good. Either it's a D1 or it's a D4, and it's not ideal. But with the constriction and the lack of facial bone when these teeth were extracted, he doesn't even have an option. If you get a heroic oral surgeon as well here to do the surgery up in the sinus, they might be able to do what we call a ramus block graft here to widen this arch. There is an opportunity to possibly do a ridge split here as well. So that means you cut into the bone and you crack that bone open, and then you put graft and you hope that it all kind of heals together. That would take, any of these cases are going to take, just with the graft healing, 7 to 12 months to try to encourage that bone to grow in a way that you can actually get dental implants in. He gets kind of an orange from the nerve height here, but it doesn't really matter because you wouldn't be putting much implants in here either. So he would really need a specialist to deal with this that likes to venture into riskier business of oral surgery. So, well, what could you do if you work outside of the nerve area? So this is what the goal would be, is to work between this line and this line. Because if you could work in front of the nerve, there isn't any nerves going through the bone in this front area here. So an all-on-4 model or anything in implants, you want to try to get some sort of support as far back as you can and sometimes as far forward as you can. And so in this case, let's look at what those teeth look like. And if you look at the bone on these teeth here, I'm going to angle that a little bit more. And let's look at this tooth here. And that looks okay. Like, that doesn't look too bad. It's very thin because the bone constricts, but we could probably put an implant in there. And let's see, I have an implant to put. Let's put those in. So that's what that implant looks like here. That would be in that position. So that's the smallest diameter you'd want to even use, and you could get something in there. So we have 3 implants going across here that could work for this case. So let's look at the bone while I go across, and this could be a site, but the fact is that it doesn't really offer us any opportunity, so we want to go a little bit more forward. And that's why we put something here, because in the next site over, you can see now we're basically the same position. We have a little bit better quality of bone, and we know that we're going to lose all this upper bone up here. They've got a thin layer here, thin layer due to the constriction and the poor facial quality of the bone. So you can put the implant in here. It could even be a little bit longer. I just did that for a basic measurement. And then you end up coming over the teeth over here. And look how little bone you've got, and the constriction really hurts you here. And now let's look at that final implant that I put in here. Take a look. So you would now drive it in here. Now the bone quality gets more poor here. The density of the bone is really hard. So here on this side, now we're looking at this left side, really gets in jeopardy because the bone quality is so much harder. So the variance in this person's bone is very different from site to site. You go from D4 to D1 and you don't have anything in between. So that makes it very, very difficult. But I believe that you can possibly get some healing into this case here. So what do you do over here? You see I don't have any implants on the left, and that makes it very hard to have a balanced bite or a balanced prosthetic over the support of the implants. And so what would you do here? So as we look at the bone, I'm going to cruise this direction, and let's look at that bone here as we go across. And you can see it just really doesn't measure up. It just comes to a knife edge, and you're way down into the jaw here. If you're trying to do that, it's too close to the implant. So let's go further away from the implant, close to the nerve. And you just got this really hard, dense bone with a real tight constriction, and it's really not a good situation. So in lieu of all these problems if you could get those 3 implants in, what could you do? You know, because this is really no man's land. It's very difficult. I have a solution for this situation right here. Not very good, but it's the only thing he's got. You look at this spread. Now, the spread being across these implant placements here. I'm just going to try to show these yellow circles as those implants. We would be looking at doing a prosthetic that would need to come out to at least about here. And then you want to do at least to about here if you want it to be symmetrical. Well, we don't have any implant support here, so maybe we have to shorten that up. So if the prosthetic comes across the arch like this, it's going to be a little shorter on the left side. So the only opportunity this patient has in my mind, aside from a lot of heroics on doing these types of fancy grafts and things like that, is to do a connecting bar. And that connecting bar would go across these implants. So he would do an overbar denture with 3 implants. And what I told him is that we would have to set up those locator attachments on the bar right into this second premolar side on the right side. But you're only going to come to the distal part of the canine side right here with the other locator attachment, and you'd probably put maybe a locator attachment here and maybe in between these 2 implants here. So you would get 4 locator attachments. This is going to be very skewed to one side. So what to do about this little area here? We don't want the denture or something really cantilevering too far back because you're going to really have a problem with support. So there is a mini implant out there that is a 2.4 millimeter diameter, and if we measure from here to here, we've got about 4 millimeters of bone. So with the reduction of the top of this bone down to do the augmentation, you can get most of the implant into this bone right here. And when you do that, you can put the little locator attachment on that one little implant. And that might be enough, if it survives, to put it right here. So I put a little implant there. So look how far down it goes. So this is where the implant is based, is way down here after you augment the bone. Maybe we can make it a little bit higher. But still, the fact is like it's not great, and that implant is pretty far down. It's close to the nerve, but you would get a little bit more support on that denture piece to maybe about this position here. And this one, you would get your denture piece a little bit more supportive, probably to about out here. So that gives you at least going into the first molar position, and this one gets you at least to the second premolar position. And that's about all you could do with this case. So nothing really on the offering in the upper, and nothing really great on the bottom, but looking at a 5-year plus plan, hopefully that this person can actually keep things clean and it stays healthy. Unfortunately, he's a smoker, so that's not good out the gate. He should, if he's going to invest and do all the surgery here, he's going to have some sort of like control on the smoking. Now, the other thing to note here, he starts off with a detached gingiva in the yellow zone, mainly because the gingiva is attached to the actual teeth. So when those teeth go and the bone drops, because all of this bone height is going to be clipped away across the ridge, then you create a red detached gingiva situation. It's very difficult to deal with that, but they seem to work out pretty well on the lower, because this tissue that ends up growing there is really fibrous, it's really tough, and if you can just get the implant to come through that, even though it's detached, it's really tough and thick, they work out okay. They work out pretty well. I don't get too many people that have that many problems with that, but there's a potential, if you're hitting with a water pick or something really forceful into that tissue, you can create an infection site right away. So that's about this case. It's a good case study to find out what is the limits of what we could do, and this pretty much pushes the limits on what we're able to do with a full arch of very difficult bone to work with from the start.